Hello students, welcome to today's class. I am Bernisha, lecturer from Emmanuel College of Pharmacy. Today we are going to discuss about a new topic from pharmacotherapeutics, that is asthma. So in this slide we are going to discuss briefly about asthma, its etiology, pathophysiology along with clinical manifestations and their pharmacological and non-pharmacological management. Okay students, let's get into the video. First, let's see what is asthma. Asthma is a non-communicable chronic lung disease. Non-communicable means it won't spread from one person to another. So it's a non-communicable, but it's a chronic lung disease. Mainly it affects the pulmonary area, that is our lungs area, and it is characterized by airway inflammations. Usually asthma is mainly mm, characterized by the inflammation. So, there will be the inflammation in the airway, that is the bronchi, bronchioles, and the alveoli. Next, it will be the airway obstructions. Obstructions means there will be some of the resistance or this may be due to the muscle spasm which may associated with the mucosal edema. Mucosal edema means nothing but there will be the accumulation of mucus in certain areas. This may obstruct the air which may passes through the airways. So first will be the airway inflammation and the next will be the airway obstructions, which is mainly due to the muscle spasm or with the mucosal edema. And the next will be the airway hyperreactivity to the aerobiological irritants. So sometimes this asthma may also caused by the irritants. Irritants means nothing but the allergens. Some of the pollutants or the pollen allergens which may also causes this hyperreactivity in the airways. So the airway inflammation, airway obstructions or the airway hyperreactivity. These are the certain characteristics which produces or which the features of the asthma, that is the non-communicable chronic lung disease which mainly affects the pulmonary area. And the next one will be the etiology. Etiology means nothing but the causes. How does the asthma causes? So first will be the host factors, that is the genetic or sex. For genetic means sometimes it may be due to our genes. So some genes may be may causes or predisposing to the airway hyperresponsiveness. Something means it may be due to some hyperresponsiveness. So this genetic conditions plays a major role in the causes of asthma. Next, in sex means both genders. In both female and males, only males are more prominent to this asthma. And the next one will be the environmental factors. Environmental factors shows that that is the allergens. Allergens means we know that some of the irritants which may cause us some allergic reactions. It may be of indoor and outdoor. Indoor means it will be up to domestic mites, furred animals like dogs, cats and mice, cockroaches, allergens and fungi, molds. These are the indoor allergens which may causes this asthma. And the next one will be the outdoor. Outdoor means like pollens, fungi, molds, yeast. It may be from the plants of some other trees which may causes some of the allergic reactions. And the next will be the infections. It will be due to the viruses. Mainly in 40% of the children, it may be due to the infections. And the next will be the seasonal. Some of the seasonal variations like from summer to winter or some rainy seasons or some cold conditions which may attacks or affects the people who may easily prone to this asthma. Usually 35% of the children are prone to this asthma due to the seasonal variations. And the next one will be the diet. Some of the foods, some people may allergic to certain foods like peanuts, eggs and wheat. So if that person takes that certain fruits, they may trigger their allergy hypersensitivity reactions. So it may lead to asthma. So these are the certain factors which causes the asthma. And the next one will be the sensitization to allergen. That means what will be the allergens? It may be like pollens or indoor allergens or outdoor allergens, but what will be our sensitizations? Next will be pollutants. That means the tobacco smoke, mosquito coil smoke, sprays, perfumes. Some of the people may fully they may be very much sensitivity towards the smokes. So these may also causes the asthma. And the next will be the respiratory infections. These respiratory infection is due to the virus. Virus may also causes this respiratory infection. Psychosocial factors. Some of the factors also causes these um, asthma. Next will be the drugs. Certain drugs such as aspirin, beta blockers, or may also causes or may prone to this asthma. So these are the certain factors which will be characterized by the causes of asthma. Next is pathophysiology. Pathophysiology is nothing but how this asthma get into our body, how it reacts in our body. We know that asthma is a very complex condition. It may be the interaction of genetics and environment occurs involving many inflammatory cells, which releases certain mediators. We know that there will be some of the airway inflammations or airway obstructions. So this may occurs involving many inflammatory cells. These inflammatory cells which releases a wide range or variety of mediators like interleukin or TNF alpha. These mediators which acts on the airways. That means the smooth muscles present in the airways and causes contractions or mucus hypersecretions, plasma leakage or edema, activation of cholinergic reflexes, activation of sensory nerves, which leads to the amplification of the continuing inflammatory responses. And the next will be after that when the inflammatory mediators gets secreted or released, there will be some of the chronic inflammations which may lead to the structural changes which including subepithelial fibrosis and smooth muscle hypertrophy and hyperplasia. This late process is less easily reversed than the acute changes and might end up with airway remodeling. So, the chronic inflammations which may lead to certain structural changes that will be subepithelial fibrosis and smooth muscle hypertrophy and hyperplasia, which will be further leads to the airway remodeling. First, there will be the release of inflammatory mediators. These inflammatory mediators leads to the smooth muscles contractions, mucus hypersecretions, plasma leakage, edema, activation of cholinergic reflexes, and activation of sensory nerves. Here, first we know that this flow chart will help to easily understand the pathophysiology of asthma. Here, first the asthma gets triggers and it leads to the inflammation and edema of the mucous membranes. After that, the mucous membrane gets inflamed or there will be some of the accumulation of fluid in that mucous membrane. And next will be the accumulation of tenacious secretions from the mucus glands. So we have already studied that the inflammatory mediators which leads to the hypersecretion of mucus. Then after that there will be the tenacious secretions from the mucus glands. And the next it may leads to spasm of the smooth muscle of the bronchi and the bronchioles. So smooth muscles in the bronchi and the bronchioles get spasmed, so squeezed. And the next there will be the decreases the caliber of the bronchioles. The bronchioles gets what? Decreases the caliber of the bronchioles. So these are the some of the flow charts which easily understand the pathophysiology of asthma. Next will be the clinical manifestation. The clinical manifestations mainly includes dyspnea, wheezing, and cough. There will be the difficulty in breathing, and it may also causes wheezing and cough. These episodes of asthma usually begins with chilled feeling, irritable, and increasingly restless. Here mainly during the night time only, it may increases the wheezing conditions, or they may feel some chilled feeling inside and some irritability. And when the time fastly move on, the symptoms gets increasingly restless. After that, it will be the nocturnal cough or breathlessness. Only it will be maximally the clinical manifestations. These symptoms are seen during the night time. And the next will be the asthmatic child may complain headache, feeling tired, or chest tightness. So these are the simple clinical manifestations which is associated with asthma. And the next will be the respiratory symptoms. In mainly when we are focusing on the respiratory system, it feels recurrent cough and post-tussive vomiting. That will be recurrent cough means that will be the persistent cough. So it will be continuously the patients will be under coughing conditions. And the post-tussive vomiting, that is after coughing the patients will vomit some of the mucus. That will be the post-tussive vomiting. Next will be abdominal pain, rarely occurs due to the overworking of expiratory abdominal muscles. We already know that when we have some coughing problems, we will feel some abdominal pain also. And the next will be the chest pain, which is present rarely. It is a rare conditions of chest pain. And another will be the comorbid conditions like allergic rhinitis, sinusitis, serous otitis media, eczema. These are the some of the comorbid conditions. Next will be the shortness of breath, prolonged expiration, VC chest, cyanosed nail birds, dark red color lips. They may progress by time to blue. These are some of the respiratory symptoms which is associated with asthma. Next one will be the diagnosis. How we will diagnose this asthma? First, we have to take the history that if a child is affected by the asthma, we have to ask them whether they have any attack or recurrent episode of wheezing. That means the high-pitched whistling sounds when breathing out. Next will be the does the child have any troublesome cough, which is particularly worse at night or on walking. We have to ask these questions when we are taking the history on asthma. First, we have to ask whether they had any attack or recurrent episode of wheezing, or that they have some troublesome cough when they have was at night or at walking. And the next will be, is the child awakened by the coughing or difficult breathing? And next will be, the does the child cough or wheeze after physical activity like any games, exercise, or excessive crying? Next will be, the does the child experience breathing problems during a particular seasons? So these are the certain diagnosis questions we can ask to a parents when their child is affected by or diagnosed by asthma. Next, physical examination. Through the look, we can understand the clinical manifestations of asthma. That is how we can diagnose this asthma. First will be the dyspnea. We know that major clinical manifestation is dyspnea, that is difficulty in breathing. Next will be the respiratory wheeze, that's accessory muscle movement, difficulty in feeding, talking, getting to sleep. These are some of the physical examinations we can easily identify through the look. Next is irritability to cough, eczema, allergic rhinitis. These are also some of the Clinical manifestations we can easily diagnose this through the look. And next will be the chest X-ray. Chest X-ray means nothing but we have to take diagnose by taking an X-ray of the chest. So we can easily diagnose the asthma. It needed only when the diagnosis is not clear or any complications are suspected. Next will be the medical management. Medical management means how we can manage, that is a pharmacological management, how we can manage this asthma. So usually we have to give oxygen because they have difficulty in breathing, so we have to give oxygen to keep oxygen saturations which will be greater than 95% in all children with asthma who are cynosed. So that will be the oxygen saturation will be greater than less than or equal to 90% or whose difficulty in breathing which interferes with talking, eating or breastfeeding. Next will be the pharmacotherapy. So we can give some quick relievers. That is, what are the drugs which is used to relieve the bronchospasm as we can when it is needed. So we can use mainly salbutamol, terbutaline, adrenaline, aminophylline. These are some of the bronchodilators which can be used as a quick relievers to relieve the bronchospasms. Next will be the preventers such as used for the long term to control the inflammations and to prevent further attacks. Next will be the steroids. Steroids are some of the drugs which is used to prevent the inflammations. Inflammations, mainly the corticosteroids are the drugs which is used to prevent the inflammations in the airway. So mainly we can we can use this prednisolone and theophylline as to prevent the inflammation of the airway. And the next will be the long-term symptom relievers that will be used to relieve the bronchospasm for longer hours. Salmeterol, formoterol, bambuterol. These are also used as the inhaled steroids. We can use with the inhaled steroids. These drugs are commonly used with the inhaled steroids. Next will be if the methods of delivering salbutamol are not available, we have to give a subcutaneous injections of adrenaline. That will be around 0.01 ml per kg. So per kg we have to give adrenaline up to 0.01 ml if we can't deliver salbutamol to that person. So next, in up to measured accurately with 1 ml strength if there is no improvement after 15 minutes. So, if we can't give salbutamol, we have to give 0.01 ml of what adrenaline. But next one, so if there is no improvement after 15 minutes, we have to repeat the dose once again. Next will be the magnesium sulfate. Next will be the magnesium sulfate. So in intravenous, we can give the magnesium sulfate, which may provide additional benefits in children with severe asthma, which can be treated with bronchodilators and corticosteroids. We have to give 50% of the magnesium sulfate as a bolus and 0.1 ml per kg IV over 20 minutes. For 20 minutes, we can give 0.1 ml per kg. Next will be the oral bronchodilators. Oral bronchodilators means we can take in as oral. So orally we take salbutamol in the form of syrup or tablets. It is mainly not recommended in the treatment of severe or persistent wheezing. During the condition of persistent wheezing, this oral salbutamol is not recommended. It should be used only when inhaled salbutamol is not available for the child who has improved sufficiently to be discharged home. If there is no inhaled salbutamol, then at that condition we have to use this oral salbutamol. Dosages for the age of 1 month to 2 years, we have to give 100 microgram per kg, maximum up to 2 milligrams, up to 4 times daily. Age will, for if it is 2 to 6 years, we can use up to 1 to 2 milligram up to 4 times daily. So these are the dosage calculation for the oral bronchodilators. The non-pharmacological management. The non-pharmacological management of asthma mainly includes education. So the education of the asthma. So the patients, we have to give the patients counseling regarding the asthma to the patients. Next will be the environmental control. So in environmental control, we have to be in the pollutant-free areas. Along with that, we have to get rid of the pollutions and will be the free from the smoking areas. Next will be the evaluations. Evaluation is nothing but we have to self-evaluate our physical as well as the mental health, and also we have to take care of the respiratory um, events. Next will be the emotional support. As the patients were very weak in the emotional support, so we have to give them a patient counseling along with the parents, and as well as the social events has also give some emotional support to the patients. Next will be the regular follow-ups. Actually, the asthma patients will have some regular follow-ups so that they can easily get rid of that asthma. So these are the some of the pharmacological managements we can use to do um, get rid of this asthma. First will be the education. So the nurse must spend the time to clear the misconceptions about the disease, sexual bias, as well as the non-communicability of the disease. So sometimes the patients may have this fear of using inhalers, steroids, as well as the um, misconceptions about the disease. So the nurse as well as the pharmacist have to spend the time to clear the misconceptions about the disease. Next will be the environmental control. So in environmental control, the most important factor of asthma will be the dust, mites, cockroach, fungus, as well as pets. So we have to get away from the pets, as well as we have to keep them away from the mainly sleeping areas. If we have possible to keep the pets outside the areas, we have to keep it outside the areas, and to get rid of the strong odors, smokes, mosquito coil burnings, etc. So when we have control in such environmental dust, mites, cockroaches, fungus, we can easily control the asthma. And the next will be the evaluating the respiratory status. So we have to evaluate the respiratory status as well as the patient's general conditions. Usually, frequent assessment of respiratory pattern. We have to assess the respiratory pattern frequently when we are in the follow-ups. Next will be the cyanosis, and next the breath sounds, vital signs, cerebral functions, etc. So these are certain evaluating the respiratory status. While evaluating this respiratory status, we can easily control the seriousness of asthma. Next will be the providing emotional support. We have to give a calm and quiet approaches to the patients. As they have trusting relationship, we have to give some reassurance, play and recreations. Next, we have also give some parental participations. Next will be the positioning. Positioning means while we are giving counseling to the patients, we have to keep them comfortable in a sitting position and supporting with the pillow. Next, we have to leaning forward with the support maybe allowed. So when we are administering oxygen as well as we are giving some ventilators, we have to keep them in a comfortable sitting positions so that they can easily get into the treatment, so that they can be stable while controlling the asthma. So the positioning and the providing emotional support will be the most important thing in controlling asthma. Next will be the administering fluid therapy. Administering fluid therapy means usually during asthma, the patients will take only less fluids. So, in order to prevent their dehydration, we have to maintain the input and output chart, and we have to maintain the fluid intake of the patients. And the next will be maintaining the adequate dietary intake. So clear liquids in small amounts, we have to give them a clear liquids in small amounts. The allergic foods we have to be avoided. Some of the patients may be allergic to certain foods such as peanuts, um, chickens, prawns, etc. So we have to avoid such allergic foods to that patients. Next is spicy and gas forming foods to be avoided. And next we have to maintain a balanced diet. So these are the some of the dietary intake we have to take while controlling the asthma. Next will be the maintenance of hygienic measures. We have to maintain a routine hygienic care so that we can maintain that dust and allergen free environment and aseptic technique. We know that the important factors for the asthma will be the dust and mites along with the pollens, allergens, some of the pets. So when we are keeping the environment hygiene, we can easily control this asthma. And next will be supporting parents and family. So the emotional support and patient participating in the care and they discuss the treatment plans along with the health educations will be the greatest of supporting in the control of asthma. So major the emotional support, the patient counseling plays a major role in controlling asthma. Okay, students, in this video, we have completely learned about asthma, its etiology, pathogenesis, along with their pharmacological and non-pharmacological management. Um, I hope this video will be very helpful in understanding the clear view of asthma. Let's see in the next video. Thank you.